Hi, this is Professor Colleen Parsons, and this is a lecture on nutritional assessment. I'm going to go through this pretty quickly because we don't do much with nutritional assessments except for when you do your health history paper, but it is kind of important aspect of working with your patients. So nutritional status refers to the degree of balance between nutrient intake and nutrient requirements. Excuse me. So what you take in and what your body actually requires that you take in. So you know that you're supposed to be eating better than you probably are, and when sufficient nutrients are consumed to support the day-to-day needs of the body can flourish. When you take in too many, it doesn't flourish quite as well, and if you don't take in enough, your body has a tendency to move into starvation and doesn't flourish well at all. There are many nutritional risk factors, including age, stage of life, ethnicity, socioeconomic class. That's a really big problem in America. Genetics, of course, lifestyle, personal food choices, and underlying medical conditions. Healthcare management are primary prevention, secondary prevention, which is screening. So the primary prevention is what your patient is actually doing. Secondary prevention is screening, work that we as nurses can help with. And collaborative interventions, which means a whole team of people will be working with a patient toward a goal. Undernutrition is often seen as people starving, their reserves are depleted, and they are not getting enough nutrient intake to meet their day-to-day needs. Malnourishment can come in every shape and size. So I have a friend, a young friend, who for a while was only eating Little Debbie snacks from morning to night. She said that about every 4 or 5 days she would have a decent meal, but the rest of the time she was just consuming Little Debbie snacks. Now, you would think that that person would be obese. She wasn't. She weighed about 130 pounds and it was 5'7". So that was seen. She was definitely, absolutely malnourished, but you wouldn't have known that necessarily by looking at her. When you see somebody who is rotund or morbidly obese, you might think that they have that they're very well nourished, but that might not be true because they might be eating many foods that are not healthy for them. So negative effects of obesity on your health are things that you know and some things that you don't know. People who have a predisposition, who are obese, have a predisposition for type 2 diabetes. Their pancreas just wears out if they're not eating healthy. Heart attacks because so much fat accumulates around the heart. Low self-esteem. Society doesn't always accept you very well. Limited mobility, high cholesterol. The list goes on and on. Developmental competence in infants and children is important because without proper nutrients, they can't grow correctly. Their bones, their muscles won't grow. Wow, that's some growth spurt. So developmental competence has to include everything that a child or adolescent will need to support the rapid stages of growth that the body goes through. And of course, women who are pregnant or lactating, they'll say they're eating for 2. Now, they're really not eating for 2 because that baby isn't very big. They're sort of eating for 2, so maybe 1 1/10. and you have to consume high quality nutrition and not a lot of the wasted calories. The government went from the food pyramid, since you all were born, from the food pyramid to myplate.gov, and I would encourage you all to go to myplate.gov so that you can see what that's all about. It's a great teaching tool for your patients. Here's a particular food plan for an aging adult. You can see how they're only eating 5 ounces of grains a day. They're only to eat, well, they're recommended to eat at least 1.5 cups of vegetables and 1.5 cups of fruit. So they're still on the 5 fruits and vegetables. Here, this would be 6. Dairy, 2.5 cups of dairy. Now, and 4 ounces of protein. 4 ounces of protein is not a whole lot of protein, but they're not using it to build muscle or usually, unless they're bodybuilders or they have a very active life. So they're not using it up as rapidly as other people would, younger people. Cultural competence is important, and hopefully in class we'll have a brief discussion about the different kinds of foods the different cultures in our class eat. So if you're from an Italian heritage, you might eat a completely different, you might have different favorite foods that your mom makes than if you're from a Jewish heritage, than if you're from a Irish heritage. They're just different. And here are religious-based diets where you can see that Judaism keeps kosher, and Islam keeps halal, and you can see what these mean. And if anybody has more questions about this, we can ask them in class. Nutritional assessment purposes. Oh, it's important to find out from your patient what they usually eat, what they would like to eat, and how we can get them into a real healthy plan of eating. Here's subjective data. So this is information you can only get from your patient or their caretaker about their eating patterns, changes in appetite, foods, allergies, those sorts of things. As far as infants and children go, baby food was interestingly developed in the 1920s. And then now people think that that's all you can give your baby, and that's not true. There are many different ways of feeding babies. My 2 youngest grandchildren will never eat baby food. Their mother has a completely different pattern of feeding them. But a lot of people don't think about the wasted calories and poor nutrition that they're feeding their children when they just think the children should be able to try these things and eat our poor American diet. Now, there really isn't such a thing. Gerber really doesn't make Big Mac and fries dinner. This is a joke. What would you like to weigh is a question that you can ask for adolescents. How do you feel about your present weight? So if you say, what would you like to weigh? That is a different question than do you think you're overweight or do you think you're underweight? You're getting an emotional sort of picture about where they are, what they think is the right thing, and then you might be able to do some true education along those lines. This cartoon, if you can't read it, says, don't step on it, it makes you cry. So while you're an adolescent and you should be eating all of these things, and quite honestly, the cafeteria does offer you mostly, maybe not as pretty as these things, but they offer you a pretty well-balanced diet, it's really not what you want to eat. So then you don't like eating in the cafeteria because these are the things that you would prefer to eat, but they're not as healthy. And you can eat these things in small amounts, but I see some of you eating some of these delicious things every single day, and that might not be as healthy for you as you think. So when you're working with pregnant women, you need to get a complete picture of what's going on for them, what kind of foods they're eating, what are they craving, how are they managing their cravings, and those sorts of things. So a history for aging adults is very important. This particular cartoon says, good news, after adjusting for BMI, age, smoking, activity levels, history of heart disease and diabetes, race, socioeconomic status, and alcohol use, it turns out you're perfectly healthy. Does he look perfectly healthy? Probably not, but all of those things are true. We do have to adjust for those. Here's a mini nutritional assessment, basically developed for the aging adult. And observation of general appearance is very important when you're assessing nutritional needs of your patient. So there is obese, which is overweight, cachectic, which is very much underweight. You're skeleton-like. You look too thin for your frame. Or edematous, which is fluid overload. These could all provide clues to the overall nutritional status of your patient. Now, trying to get a height measurement so that you can do an accurate BMI can be difficult in a patient who can't hold still or can't stand up straight. So there are a couple other things that we can do, like arm span or total arm length. And if you have an opportunity to do that during your labs when you're practicing other things, I should make a note. If somebody can make a note on the board, that would be great. Practice arm span. I have a should put this out. I have a, what do you call those things? Tape measure. Oh, here it is. Tape measure here in my office. And I'll try to remember to take that in. So you want to objectively observe, your patients. We don't have any of these tools, but skin fold thickness can determine whether there is an excess of body weight on your patients. And here is how much weight somebody should gain generally, depending on their height and lots of other things, what their starting weight was. But their normal weight before pregnancy, they should gain, if they're normal, within their low BMIs, so they should gain 25 to 35 pounds. But if they're obese before pregnancy, we're really trying to get them only to gain 10 or 11 pounds. The height of a patient will be affected. Now, here's the same person at 45, 65, and 85. So when you have a rounded back here, that's called kyphosis, and it has to do with the little tiny breaking down of bone in the spine. And then, of course, they usually try to grow together and causing this lump here, a hunchback sort of appearance, the leaning forward sort of appearance. Some people have such a complete kyphosis that they're almost bent over in half when they're walking. So you see this woman started out at that height, and now she's at that height, even though her arm measurement probably is the same, so it probably is a similar height. Now, I used to be 5'6". I'm down to 5'5", 5'4.5", somewhere around there. Laboratory studies are objective, so now we're getting into more objective with this sort of a picture and with this, with blood work. We're doing blood work to find out how the body is faring as far as its nutritional status. A serial assessment, we might, if somebody is trying to lose weight or has a nutritional intake problem, we're going to do a serial assessment on them. And what a serial assessment is a patient coming back multiple times. So you're going to make an appointment every week, every 3 weeks, whatever it is. That's what a serial assessment is. Approaches to weight loss. This is kind of cute. Don't forget what you are, what you eat. I need to eat a skinny person. Well, that doesn't really work, does it? And it can be very difficult for somebody who is predisposed because of their DNA to lose weight. It can be, for somebody like me, it's almost impossible. I've tried and tried and tried, and it just doesn't work. Classification of malnutrition. Malnutrition, there's overnutrition or undernutrition. Overnutrition leads to obesity. Undernutrition leads to these. Here's bone problems caused by nutritional deficits. So here's normal, and then here's rickets, where the bone is actually bending. It just doesn't form right, breaks. So summary of your nutritional assessment checklist. You're going to be getting a good dietary history. You're going to inspect the patient. You're going to measure the patient. You're going to do laboratory tests. But the very most important test that you can do for a patient when they come in for just a regular assessment is check their weight. You check their weight, and then the next time they come in, every time you check their weight to see if something is going up, something's going down, where are they? So you're going to also check their height at some point, or at least get them to tell you what their height is, and you're going to be checking their BMI. That's our data. I don't particularly like the BMI, but it is what it is, and that's the data we have to work with. Thank you very much. Have a good day.